Hey guys, welcome to my YouTube channel. It's my first video. Thanks to those of you that supported this on the Instagram page as just another way to get some information out there. Today we're going to talk about very briefly one of the most important topics that I think pre-hospital providers need to understand, which is shock. It's great to be able to identify that your patient is in shock, but more importantly, we need to understand why so that we can treat them appropriately. So first, let's talk about what is shock, right? No matter what the cause is, it means that there is not adequate perfusion to our tissues to sustain life there, right? So our blood carries oxygen and nutrients down to our capillary beds where it's delivered to our cells and then our tissues and our organs. But if we can't get enough blood flow there for whatever reason, then eventually those cells are going to start to die. So we need a few things to maintain adequate perfusion. First is we have to have enough good stuff in the tank, right? So that could be blood or just volume in general. But if we don't have enough volume or enough blood, then our patients are not going to have adequate perfusion. So the first type of shock that we're probably most familiar with is hypovolemic. In trauma, we're usually dealing with hemorrhagic shock, where a patient is bleeding either internally or externally or both. So our goal is to stop the bleed as quickly as possible and refill the tank with the appropriate type of fluid. So in trauma, that's going to be blood products. Saline is not good for these patients for a whole host of reasons. So getting them blood products and surgery as soon as possible is what's really going to save their lives. We can have hypovolemic shock patients from other types of volume loss as well, like a geriatric patient who's had norovirus for a week and she's had nausea, vomiting, and diarrhea, and she's profoundly dehydrated. In those cases, we can replace the volume with a crystalloid, and that's going to be far more effective for that patient. So that's not having enough good stuff in the tank, right? The next type of shock is cardiogenic, which means our pump isn't pumping adequately. In order to have good perfusion, we have to have a pump that works, right? Without it, our blood isn't gonna go where it needs to go. So at the root of cardiogenic shock is problems like an acute MI, right? Where a patient has a massive STEMI, it knocks out their left ventricle can't pump anymore, their cardiac output drops, they become hypotensive, fluid starts to back up into their lungs because the left ventricle can't move volume forward, they look shocky, they look yucky, right? We need to be cautious with fluids with these patients, be a little more conservative with it so we don't overwhelm an already sick heart, but they may need a pressor like norepinephrine to help support that perfusion if it's truly getting to a dire state. Obstructive shock can sometimes be considered a shock of its own, or it's a subcategory of cardiogenic. But either way, obstructive shock causes the pump to not pump so well because it is physically obstructed by something. So a good example of this is a tension pneumothorax, where the air in the pleural space gets so full that it starts to squeeze the mediastinum, and it squeezes the heart, and it squeezes the vena cava so that we can't get blood return and our cardiac output drops. We fix that by darting the chest or doing a thoracostomy. Other examples are a cardiac tamponade, where the pericardial sac gets full of fluid or blood and it squeezes the heart. It's like the heart is stuck in a water balloon and it can't expand and contract adequately. So those patients are going to present shocky. And even a pulmonary embolism will result in an obstructive shock. So you have a blood clot that is obstructing the pulmonary arteries, either one or both. The right ventricle is what pumps out to the pulmonary arteries. So it's trying to pump repeatedly against a roadblock, and when it can't move past that, eventually that right ventricle is going to get cranky and tired and dilated, and these patients will go into right-sided heart failure. Finally, we have distributive shock, where our tank is too big, right? So far we've discussed not having enough volume, not having a pump that works, and finally we're talking about a tank that is too big. It's not the right size. 3 different categories of this. In septic shock, these patients have an infection that goes systemically that causes an inflammatory response that causes the vessels to vasodilate and get leaky, and they end up in a distributive shock that can be addressed by fluids and pressors. Anaphylactic shock, that histamine release from that systemic allergic reaction causes vasodilation, and again, going to be fixed. It can be addressed with fluids, but primarily it should be fixed with epinephrine. And then finally, we have neurogenic shock, which primarily happens with our spinal cord injuries, and it causes a disruption of the sympathetic nervous system signals below the site of the injury. Remember, our sympathetic nervous system is what causes an increase in heart rate, an increase in blood pressure. It causes vasoconstriction. So without that, the patient's heart rate remains low to normal, their blood pressure may be low, and their skin is flushed and dry because they don't have that normal vasoconstriction response from the sympathetic nervous system. So these patients look a little bit strange in comparison to our other shock patients, but that needs to be identified quickly. In our trauma patients, all shock is hemorrhagic until proven otherwise. So that's an overview of your different types of shock. We'll do other videos that dig a little bit deeper into each one, and see you next time.